G'day, so this is Bob, and we've been dispatched to Bob for a 10. So he's come down with chest pain and a subsequent collapse. He's 70 years old. He's had an MI in the past, about 5 years ago, and today he had this acute onset chest pain and then a pain that's very different from usual. He's had a near syncope and he's feeling really dizzy at the moment. So when we've arrived, he's been really pale, cold and clammy. He was opening his eyes to us, so to voice. He was unable to obey commands, so I tried to get him to squeeze my hands. He couldn't do it. And so we gave him a motor score of 5. In terms of verbal, he was able to give us some history, but he's now declined a little bit, so he's getting a bit more confused, so we're giving him about a 3 and a 4. So what we're going to do, because he's real pale, cold and clammy, is we're going to lay him on the floor, and then we'll do a more formal assessment. Cool, so we've put Bob onto the ground, seeing he's quite pale and clammy. So we're wanting to do an assessment to see what's going on. There's obviously a serious issue here. So what we want to do is get some leads on and have a look at what kind of rhythm he's in. So we'll start with 3 leads, seeing as he said he had some chest pain. He's got a history of RHD. So we'll have a little look. We'll just change to a lead that we can look at everything. Cool, so I'm seeing a sort of wide complex tachy. I'm going to feel for a pulse. So I'm not feeling a radial, but I feel a carotid. So it looks like ET, pulse creating BT. So what we're going to do, the rate's about 160s, we're going to call for some backup.
Patient.
So AUT1 calls control.
Yeah, you go ahead, AUT1.
Can I request an R50 please, patient status 1 conscious VT.
Copy that.
Perfect, cool. So what we want to do now is we want to prep for cardioversion. A couple of other things we may want to do is we want to go through some differentials, and particularly with VT, we want to make sure that we don't have SVT with aberrancy. So there's a couple of things we can look for. We can do a 12 lead if there's precordial concordance, then that leads more towards VT. The fact that he's a little bit older, so Bob's 70, with a history of IHD also sort of ears more towards VT than SVT. If we do a 12 lead, if he's got right axis deviation as well, that leads more towards VT. So we can also keep an eye out for caption and infusion beats, which is sort of the underlying rhythm that's going on while the ventricles are taking over. So the first thing to do when we have conscious VT is to determine their cardiovascular compromise. So we've put on a blood pressure cuff, so while that's inflating, we'll also want to check BGL, because any sort of changes in levels of consciousness, we want to assess the BGL. So that's come back at 7.6. So we're not looking at anything overly too high or too low. We'll take a temperature as well. 37 was his temperature, so that's within a normal limit. His blood pressure has come back at 70 on 40, so that is severely hypotensive. So we're looking towards that more moderate to severe compromise. The main indicator between the two is the fact that he cannot obey commands, so that puts him in the severely compromised, that's status 1. It also changes what we're going to do for cardioversion, but we'll talk about that in a minute. So we've got a decreased GCS, we're hypotensive, we had some chest pain, and if I auscultate the lungs, which I'll do now, we could hear some lung sounds that could indicate something. So a quick listen. Cool, and I'm hearing some pretty coarse crackles in there, so you could have some pulmonary edema going on as well. So we want to start prepping everything for our cardioversion. So we want to put the pads on because VT will always deteriorate into VF if it's not reverted. There's a couple of ways we can cardiovert. One is chemically, but at this level the patient's too significantly compromised to go down the chemical route, so we're going to do an electrical cardioversion. Cool, so a really important thing to do, gain IV access, which luckily I've already done. So we've got a large bore in the left ACF. We've attached pads. The reason why gaining IV access is important is if the patient is conscious and can obey commands, we want to sedate, usually with ketamine. Again, while we've called for an R50, we need to request an R50 when we're going to administer ketamine. But because this patient cannot obey commands, we're not going to administer ketamine, and we're just going to go straight for a cardioversion. So before we get into our sort of cardioversion checklist, we also want to prepare for resuscitation, because there is always that risk with cardioversion, with the patient going into cardiac arrest. So we want to just get our airway gear ready. So we have an LMA, OPA, bag valve mask. We also want to check our patient's oxygen sats. Below 94% we'll want to be giving oxygen, and even though we are in the high flow catchment at the moment, depending where you are, will depend on what sort of oxygen you're delivering. We've put our oxygen sats on. He's a little bit low, he's saturating about 90, so we've put on some high flow oxygen just to help with his perfusion during this intervention. So a really important aspect of cardioversion is using cardioversion checklist. It's quite a difficult and dangerous procedure, so we want to make sure all our boxes are ticked before we go ahead. So in our pocket CBGs we have a cardioversion checklist. What you'd want to do is get someone to read out the checklist, and you retort and make sure that you've done it, just so it minimises any error. But for this scenario, I'll read out each point in the checklist and then state if I've done it. So the first on the checklist is to place the pads either in the apex or sternum position, so in addition to the electrode. So we have apex sternum and the electrodes on. Defibrillator's in manual mode, which we put in earlier. So now we want to sync, and so what we're going to do is press the sync button, and what you're looking for is a sync triangle on the R wave. The reason why we want to do that is we want to minimise any RMT, which can put the patient into arrest or to SARDS. We want to select the lead with the most visible R wave, so the way we can do that is you can filter through your leads there, but this lead 2 looks like it has quite a nice R wave on there, so we'll leave it as that, and we're seeing a nice sync. And the next on the step is ensuring the patient has adequate sedation. Like I talked about, if this patient was conscious, we would be giving some ketamine to help with it, because it's quite a painful procedure. Because this patient is unconscious, we're going to cardiovert without ketamine. Next up is selecting the joules. So we've already selected the joules up to the higher, or the maximum charge. Another really important aspect in this is to inform the patient what's going on. So Bob is still conscious. He can understand what's going on, so we want to tell him what's going to happen. It's not a particularly pleasant intervention, so let him know that you're what you're planning to do. Make sure there's consent there, his other options and such. It's just some of the patient rights. So at the moment we've synced on, so we're going to want to charge up, confirm everyone is clear, and then deliver a cardioversion shock. So we're going to charge up. So that's charging, and again the same as like in a cardiac arrest, when we shock we want to make sure that everyone's clear. So I don't want to lean over and hit the shock button, so I'm going to come up around, make sure they can still visualise the screen, we can still see sync there, everyone's standing clear. Because we want to shock, so we want to press and hold, and when we press and hold we want to look at our patient. So shock delivered. Cool. Once the shock's been delivered, what we want to do is reassess. So we want to see if we've reverted the rhythm or if it's stayed the same. If we've reverted the rhythm, interpret it, treat as appropriate. If we're still in conscious VT, then we can re-cardiovert. So again, check for a pulse, redo your ABCs, and with these LifePak 12s, it goes out of sync mode, so if you're going to re-cardiovert, just make sure you press sync again. G'day, Elliot here, doing my RSI assist OSCE for ILS. So today we've been dispatched to a 40-year-old male. He's fallen off a roof 2 stories high, approximately 6 metres, landing on his occipits at the back of his head. He was water blasting. His next door neighbour is called. She's got a Zimmer frame, so she can't really help out, and she's kind of buggered off. So he slipped and fallen off, hit his head, and we've been called to assist. So when we've arrived, we've noticed an isolated injury to the sort of back of his head, so his occiput. So there's a boggy patch, approximately 6 centimetres in diameter. He's lying supine, he's decerebate, so he's sort of posturing outwards, which is a sort of motor score of 2. He's quite restless and rolling around. His eyes are spontaneously opening, so we're giving that a score of 4. But verbally, he's just grunting, not making any sounds that are comprehensible, so he's got a verbal score of 2. So in total, he's got a GCS of 8. So what we're going to do immediately is call for some backup for an RSI. So AUT calls control.
Go ahead.
We have severe TBI requesting RSI endorsed R50, please.
Copy.
Cool.
10 minutes. Can you
Awesome.
prepare for the RSI checklist?
Will do. Cool. All right. Cool. As very similar to the cardioversion, RSI is quite an invasive and dangerous procedure. So we have a checklist that we carry in our pocket CPG. So I'll be running through. Again, normally you'd ask your offsider to ask you each particular segment, and you would retort with if you've done it or not. But for this video, I'm just going to read it out loud. So the first one is attached nasal prongs without oxygen. So we have some nasal prongs here, not attached at the moment. To go. Then we want to pre-oxygenate using a reservoir mask. So it's a reservoir mask, it is a P1, we don't have an adult one around, so it's unfortunate. So we can either use that or the bag valve mask. So we wanted it about 10 litres per minute, and if we're bagging, we want to have PEEP on there at 5 centimetres of water. We want to attach ECG, also get a blood pressure, so NIPV and SpO2. So if we turn on our 12 lead, or our monitor rather, we'll just put it into manual mode. And select a lead. We just want to monitor his cardiac conditions. You also want to prepare capnography, so you want to put in your end-tidal CO2 and have it primed. This is ready for when intubation occurs. We can attach it straight to the ET tube. So getting back some vitals, we got as I said, a heart rate of 50, a blood pressure of 160 or 90. We do have a TBI, so we want to be treating for severe TBI, so we want to keep that blood pressure above 120. We've got a rest rate of 12, it's irregular. This again is showing that there's obviously some sort of injury to the brain that's causing an irregular rest rate. Next on the list is making sure that the monitor is a nice clear view, and then also leaving a bit of space on the patient's right side for when the ICP gets there for intubation. We want to gain IV access, preferably in 2 sites. For this video, I've just got one, so we've got one in the left ACF there, and we want to prepare a running line of sodium chloride, which we have up there. We want to position the patient for optimal airway control, so that's getting the patient into a good sniffing position, making sure we have a nice chin lift, head tilt sort of position to maximise that airway position. Cool. Next on the list is placing an ET tube holder with a strap underneath. It's again here, so this is when the ICP intubates, it's used to hold the ET tube. Next, we want to ensure that the suction is working. So again, this should be part of your criticals, but we'll just recheck. It's working. And you just want to have the rigid catheter underneath the head there, because that's going to be the side that's going to be utilised when intubating. We want to have a manual bag valve mask, so if you're not using it, if you're using a high flow or a non-rebreather, just have your bag valve here with PEEP on, so make sure that your PEEP is selected to 5 centimetres of H2O. We want to get a set of vital signs, so we've already got a blood pressure, a heart rate, a rest rate. The others you can do, there's an altered level of consciousness, always check your BGL, go through your AE/IOU tips, but sort of monitor for any changes. You just want to trend any changes. If it's appropriate, you can update your oncoming ICP with a set of vital signs, so prepare them for what they're going to walk into. Then we want to prepare the area, so we want to clear up anything that's not needed, so just tidy up things that are lying over, trip hazard and such like that. If the patient's not in the ambulance, which is this case, he's fallen off his roof, make sure there's access to both sides, so don't have sort of stuff lying around, or if there's chairs and beds and whatnot, move it. And then if you are in the ambulance, again, just clear as much room as possible. Cool. There's a high chance that intubation can fail. In that case, we have a post-intubation or failed intubation drill that we can refer to in terms of reassessing and moving forward. So if the ICP is unable to visualise the cords in the first 15 seconds, or is unable to intubate within the first 30 seconds of laryngoscopy, then that's classified as a first fail. So we'll remove the ET tube. We'll manually ventilate, so that's with our BVM, with our PEEP on. We will retry with a bougie, and this is when it's really important for your RSI assistant to know what's going on and their role. So what will happen is instead of using an introducer, the RSI officer will use a bougie to visualise the cords and pass it through, and then once he's passed it through, he'll get you as the RSI assistant to hold that bougie in place and then also pass through the ET tube. So that's got to be something you've got to be aware of for that second round. You can also optimise the position, so move around. You can do anterior tracheal pressure and move it up to the right to try and get a bit of visualisation of that vocal cord, and the ICP can also look at using a different blade. If that fails, and the way that can be measured, if there's not an end-tidal CO2 of above 5 centimetres of water within the first 3 or 4 breaths, that's classified as a second fail. And what we can do there is we'll remove the ET tube, we'll place in an LMA or an OP airway or MP airway. If we try and ventilate and we still can't ventilate, then that's when we're going to move on to a cricoid. So that entails making an incision to the cricoid membrane and inserting the ET tube through there. So they're sort of our options post-intubation if it's not successful. A really important aspect when we're doing any intervention on the road or anywhere as a medical professional is making sure we're being culturally and ethically safe. The HDC Code of Rights is a really good place to turn to in terms of this scenario or cardioversion, making sure even if the patient can't obey commands, if they are able to understand what you're saying, you need to explain the procedure to them, their other options, what the sort of risks and benefits are, so they can make an informed decision. In terms of cultural competency, a lot of the patients we go to don't speak English, and being able to converse and let them know the benefits and risks of the procedures we're doing can't always be conveyed, so you can either call for a translator if a family member's there who can translate for you. That can be a port of call to make sure that you are fully informing that patient. So that's just another aspect we've got to be really careful of. In terms of when the patient goes unconscious or to the point where they cannot obey any commands, there are clauses in the Crimes Act that can allow us to reverse sort of life-threatening issues if it's in the patient's best interest. So they're just some considerations to keep in mind when we're out in everyday practice.